Yeah, so my talk is entitled How to Conduct a Systematic Review and Meta-Analysis. I'll be essentially taking you through all the steps, and they have all been covered by Dr. Meenu Singh. So I would like to begin with a little bit with the history of EBM in the global literature. So here on the screen you see two eminent scientists. They are known as the fathers of evidence-based medicine and systematic reviews. One with the gentleman with the cigar is known as Dr. Archibald Cochrane, and he was a dental epidemiologist in the UK, and he was a very person who believed in the value of randomized controlled trial. He was a proponent of RCTs, and he used to think that the results of RCTs, if used methodologically, they can improve the services in the NHS. So Ian Chalmers was another scientist, epidemiologist, and he was an obstetrician, and he believed immensely in the works of Archie Cochrane, who had written a book known as Effectiveness and Efficiency, Random Reflections on Healthcare. That is the book he's famous for, Archie Cochrane. So Ian Chalmers was very much influenced by Archie Cochrane, and he did what was proposed by Archie actually. So he went back in the years 1978 and 84. He went back to the literature of 15 journals. He hand searched them. There was no Cochrane library at that time. So he hand searched them through the years, 4 years, and he found 3,500 randomized controlled trials. He actually appraised and summarized them, and that became known as the Oxford Database of Perinatal Trials. So that formed the basis of forming the Cochrane Library that was formally established in the year 1992. And in this picture, you will see, apart from Archie Cochrane, David Sackett and Gordon Guyatt. They are from McMaster University, also known for their work in the area of evidence-based medicine. David Sackett is also known as the father of biases. He has, made the literature about the biases. And Gordon Guyatt is the scientist who coined the term evidence-based medicine. So Dr. Meenu just skipped telling you that in the year 1995, centers of evidence-based practice were formulated around the globe, and in India also the process began around that time. And the Vellore Center of South Asian Cochrane Network and Center was established in 2007. That was funded by ICMR. And in the year 2011-12, we established the Advanced Center at PGI Chandigarh, from where so many people have been trained now, I think, all over India. And you have a faculty already who are going to interact with you today. So why do we need systematic reviews? Because there are many trials and many articles published every day. It is very difficult for any professional to keep abreast with the latest literature in his area. And there are so many biomedical journals in print, and there are equal numbers in e-journals. So, and not all studies are equally well designed or interpreted. Therefore, systematic reviews come handy because they identify, appraise, and synthesize research-based evidence and present it in an accessible format, so we can understand what is the evidence in the area. This is something known as the pyramid of evidence, and I think all of you, 10 people I counted, have already done systematic reviews. So all of this may sound to be quite familiar to you, but just bear with me because there are many who are going to be new starters in the area. So the unfiltered information comprises of case reports, case control studies, cohort studies, and randomized control trials. Although randomized control trials are ranked very high in terms of evidence, but there is also an area which is known as filtered information that comprises of critically appraised individual articles or article synopsis. Then there are critically appraised topics, evidence synthesis, and guidelines. And you may be aware that guideline formation takes a lot of systematic review into consideration, and they are graded for evidence. And then on top of it is the systematic review, which forms the basis of evidence-based medicine. And why it is on the top of the pyramid is because of the rigorous methodology. That's why I would like to lay more emphasis on how to go step by step into the systematic review process. Systematic reviews are also peer-reviewed, and they have a larger sample size than an individual study. Therefore, they ensure the highest quality of evidence. This graph shows you the popularity of meta-analysis in the early years of 1993 to 2004, and even today we know that more and more meta-analysis are getting published. There is a journal of evidence-based medicine, and there is a journal of by the name of meta-analysis under BMC. Definition I will not again like to repeat because it has been taught to you by Dr. Meenu Singh. However, the last point, which says that a systematic review should be based on principle of hypothesis testing, and the hypothesis must be conceived a priori, is most important to remember. And the second most important thing to remember is we want to avoid bias in all stages of a systematic review process. And how we do that is there are 3-4 things to keep in mind. So traditional reviews, all of us have done 1 or 2 by reading the literature and bringing out a publication, but you may read this definition. It says that traditional narrative reviews, authors pick and choose the studies they discuss and the depth at which they discuss them. Consciously or not, their biases and interest in the field affect how they present the findings of individual studies. So it is same like we have head of departments and very experienced clinicians who come and tell us in every ward round that in my experience I have found this. So like that. So that is not something which is akin to evidence-based medicine. So individual experience do not count. You have to, in an unbiased manner, look through the literature and understand what is the correct evidence. So this table shows you the differences between a narrative and systematic review. You can see that the sources that have been searched under a narrative review are usually unspecified, maybe potentially biased. And in systematic review, they are specified, comprehensive, explicit, because you have a written down search strategy with all key terms which refer to all your PICO terms. Then selection of studies is again in narrative review unspecified and biased, whereas in systematic reviews, it is criterion based and unbiased. An appraisal of the studies that you select may be variable. However, in a systematic review, it is very rigorous and critical. So you assess risk of bias of all studies that you include in your systematic review. And synthesis may be qualitative in most of the narrative reviews. However, in a systematic review, you also do meta-analysis, which is a quantitative synthesis. And inferences may be evidence-based at times, but in a systematic review, most of the time, they are usually evidence-based. And this slide also was shown by ma'am. So what are the characteristics of a systematic review? Clearly stated title and objective with predefined eligibility criteria for studies, explicit and reproducible methodology. What we mean by this is your methodology should be written in a way that a person who wants to update your review few years from, so each systematic review needs to be updated after two years. So the next team of people who are undertaking your systematic review to update, they should follow the same methodology which you have already written, and they will just update with the new studies which have come into the literature since then. Explicit and justified criteria for inclusion or exclusion of any studies. And ma'am also told you that in a systematic review, you need to create a table of included studies as well as a table of excluded studies, giving a reason why any study was excluded from your review. And risk of bias, we have to assess very rigorously for all the studies being included, and then we clearly analyze the results of all eligible studies. And statistical synthesis of data, which is meta-analysis, may be a part of your systematic review, and it may not be, depending upon what kind of data that you are obtaining from your studies. Then a structured report of the review. So here we come to a team. So ma'am told that systematic review is a teamwork. One individual scientist cannot complete a systematic review because at every step you need to take care of biases. So you need 2 persons to repeat all the steps of a systematic review, starting from title, abstract search and data extraction. Everything needs to be repeated by 2 people who are repeating it individually and then discussing their differences. So the teams should comprise of people with different areas of expertise. There should be a clinical person for the clinical question that is going to be reviewed. Then a person with a statistical background who knows the methodology of a systematic review. Usually Cochrane prefers people who have already have one Cochrane review should be part of the team. And a library scientist, which is very important, because search is, all of us learn search and conduct searches, but a library scientist is essential because there are many databases to be reviewed and the nuances are known better to the librarians. So this allows, the teamwork allows for double checking of inclusion of studies and also for data collection. As I said, it is a stepwise process, and the first step is to think about a focused research question using the PICOS approach. And then we have to write our protocol. Writing a protocol forms the backbone of a systematic review, where you review all your inclusion exclusion criteria is written down. You have your methodology of data extraction, who will perform what. These are all outlined here, and you follow that. So when you have completed your protocol, you can also publish it. If it is a Cochrane review, after the title gets registered in the Cochrane library and you are given by the Cochrane review group the format to complete your protocol, and after being peer reviewed thoroughly, it gets published in the Cochrane library, and then you can start with the full review process. So after your protocol has been published, they will share with you the RevMan template to complete your review. So when you are writing the protocol, not all headings are highlighted. Only few you have to summarize your, the explanation about the protocol. And once you have completed, then you can write the full review in the RevMan, which is a software, Cochrane software for completing systematic reviews. So if it is not a systematic review under the Cochrane, then you are free to register your protocol in the Prospero, which is an international prospective register of systematic reviews. So registering a protocol is helpful because your title is known to others and nobody else will attempt to initiate another review because it will be repetitive, and then it also helps you being peer reviewed. This is again showing the steps. Define a question, find out your PICOS, and then based on the key terms coming from your PICO statement, you conduct the literature search. And for doing a systematic review, you need to search more than 2 databases. At least 3 databases need to be searched, and you need the help of a library scientist. Then after you have the articles have been retrieved, then you remove duplicates, enter them in a review manager, and then you sort them out using Covidence. You can do your title and abstract screening. There are, however, other tools also like Ryan and EPPI Reviewer. Why we need to formulate a review question? Because we want to be very specific about what objectives we are going to undertake. There should be no confusion when you are conducting the review, so that you have a written protocol and you go back and read what was mentioned in your objective and you just follow that process. For determining the eligibility criteria also, like depending on the question, you will see whether you need children or adults in your review, whether it you need to consider gender and other criteria. So it also helps you searching for studies because each term, your concepts are mentioned in your review question. So it also helps in searching, collecting data from studies and presenting the findings. So it is very important to formulate a review question first and there shouldn't be any ambiguity about what your research question is. So once you have a published protocol, it will be very easy. So this is again a 4-part review question. Patient, it may have disease or condition, so it should also include the stage, severity, any demographic characteristics. And then you have intervention, what type of intervention, or exposure if it is observational study. Then consider the dose, duration and timing and route of your intervention implementation. Comparison, whether you will have absence of risk or treatment, a placebo or alternative therapy, and outcome, whether dichotomous or continuous, mortality, morbidity, quality of life. Everything needs to be penned down in your protocol. So the PICO and the study design filter. So once you have formalized your research question and you know what kind of studies are going to be included, you will have this, the this diagram will help you understand how the most likely to address your question, the studies that are most likely to address your research question will be found in the intersection area of these three concentric rings. So as I said, we have to develop a search strategy. We have to search three databases, Medline, Embase, Central, and others. And we also have to search in the trial registries, because at the time of conducting our systematic reviews, many studies would be ongoing and not yet published. So we have to look up clinicaltrials.gov and Central Clinical Registry of India and other WHO website of clinical registry. So we have to look for ongoing trials and be in touch with the authors who are conducting those trials at that time, because sometimes you may want to interact with them and ask for their data. And also during your updation of the review, you will again check in the trial registry whether those studies have been completed, published, and then you can include them in your review. One also needs to hand search key journals for cross references, and at times we need to have personal communication with the authors of studies, of ongoing studies, or with, if you find, sometimes in conference proceedings there are abstracts published, however you are not able to get the full publication, so you will have to write to the authors, and it is a very tedious process. That's why systematic review take a long time to complete, because sometimes the authors may come back to you with your paper and sometimes they may not share their data with you. So that becomes a difficult task. And why this is important? Because when we are doing a systematic review, we want to have a comprehensive search. We also want to search the grey literature, the ongoing studies, and everything. Otherwise, tomorrow we publish and then again it becomes redundant unless we are comprehensive in our methods. So all of you are, I'm sure, aware about these Boolean logics. So there are three common Boolean logics: OR, which covers both by which you connect the two synonyms of keywords. So this gives you the whole dimension of the ellipse, gives you results. This is the Boolean logic OR. The AND is a Boolean logic by which you connect the strings of your concepts which are connected with OR. So that is the second Boolean logic, very important, and here you get the intersection of the two ellipses. So studies which are, having a common, which fall in the common area will be detected here. And there is another Boolean logic which is not, which shouldn't be used very frequently because that's very dangerous and it excludes many studies. So this shows you a search strategy for one of our reviews. Here, just wanted to emphasize that there are 5 concepts and each synonym has been connected with OR, the Boolean logic OR, and in the end you connect all of them using the Boolean logic of AND. This is what forms the search strategy. After having done the search, we have to now select the studies, and eligibility should be checked by more than one reviewer. And we have to develop a strategy how we are going to resolve our disagreements. Having a senior person in the team is helpful. And we have to keep a log of excluded studies with reasons given for the exclusion, because that also needs to be published. This is something known as the Prisma flow diagram. It is a must in a systematic review. You have to show to the readers how you have done your search and how you have excluded how many records at what stage of your searching. So this is an example of a filled Prisma flow chart. Then comes the stage of data extraction. And Dr. Meenu Singh already told you that you need to pilot your data extraction form. You have to create a data extraction form based on your study requirement. And then you need to pilot on a few studies. And after extracting data, what kind of data we extract? We extract data for characteristics of studies, like year, the publication, the details, where the study was conducted, and what was the PICO in that study, participants. So we'll come to that. And then we also have to extract data for quality assessment. And then the last is the numerical data that is important for the meta-analysis. This is an example of a characteristic of included study table. What all information is covered here? Like for the method section, you take from the published article what methods they followed, summarize it. For the participants, what kind of participants were there and what kind of intervention they had used, what dosage, what did the group 1 and group 2 receive. Then you mention the outcomes, and also under notes you mention what was the setting of the study to understand. Later you will use this information for generalizability purpose and for grading purpose. So for all included studies you need to create a table like this. So the steps we take to minimize bias in data extraction is that we design and pilot data extraction form. We consider data extraction by more than one observer. One is a method and topic expert and to extract. Then we express agreement statistics also. Kappa statistics also are sometimes reported in how we extracted data. And we write down how we are going to handle the disagreements and handling multiple reports of the same study. Sometimes we find that one study, full report has been published in one journal, and then there are more publications in other journals. So duplicate, and with some variation in outcomes, there are more publications from the same study. So in a Cochrane review, what you have to, it is recommended that only the full report, one study will be reported and the other publications will be considered under that only. Like it is say Singh Minu 1992 one study, and then there are other papers, so they will be considered as Singh Minu A, B, like that. So they will not be counted as different studies. All findings from the same study will be reported in one place only. So the risk of bias for different kind of studies, now I'm deviating a little bit from the interventional studies. So for all kind of studies, there are checklists to find out the risk of biases. For these are all in the CASP website, checklist, NIH quality assessment tool, JBI critical appraisal checklist, SIGN methodology checklist, Newcastle Ottawa scale, observational studies. For case control studies, similarly, it is listed the names of the tools: CASP checklist, NIH quality assessment, JBI critical appraisal, SIGN methodology, and Newcastle Ottawa scale. So coming to the randomized controlled trials and interventional studies, when we are doing, so where all these are the places where we will find risk of bias, possibly in sequence generation, in allocation concealment, blinding of participants, personnel and outcome assessors, incomplete outcome data, selective outcome reporting, and other sources of biases can also be there, such as temporal, geography, linguistic constraints, etc. And how we take care of them, the Cochrane has different Cochrane tools, and this also was shown to you: risk of bias table, risk of bias graph, and risk of bias summary figure. So this is a risk of bias table in the RevMan, and when you assess each study for the quality and to assess the risk of bias, you have to give authors your judgment as low risk, high risk, or unclear risk, and you have to support your judgment by giving quotation from the article why you thought you have to justify your judgment. So in the support of judgment, you have to mention in sentences why you thought it was unclear or high risk. Then ma'am has already shown you this graph, the risk of bias graph, which gives a graphic representation of the risk of bias. Green is risk-free, which is low risk of bias. Yellow is unclear, and red is high risk of bias. And this is the risk of bias summary figure, where all studies and how much risk was there in which aspects of the trial has been mentioned in this graph. So overall, you can see that not much risk of bias was there in this review, which is being conducted. So after doing the risk of bias assessment, then we can think that whether we can collate the data, summarize the data, like can we do meta-analysis or not. So let us talk a little bit about meta-analysis, although all of this has already been shared. Again, it is a kind of repetition only. So this is an optional part of a systematic review. A systematic review may have a meta-analysis or it may not have a meta-analysis. So you may just end up doing a qualitative narrative synthesis of the evidence because you didn't find the data homogeneous enough to combine in a meta-analysis. So principles of meta-analysis. Each trial is analyzed separately. Patients in one trial are never directly compared with those in another trial, and the summary statistics are collected or calculated for each trial, and then each study is weighted so that some contribute more than the others to the pooled estimate, and these summary statistics are then added together to give the meta-analysis. Why we perform meta-analysis is because it increases power, because we are combining many studies of smaller sample sizes. It also improves precision of estimate, and it quantifies treatment effects and their uncertainty, assesses consistency of results, and it also helps us answer questions not posed in individual studies, factors that differ across studies, and settle controversies from conflicting studies or generate new hypotheses. So when there is equipoise in the literature, we have publications, some of which are favoring the intervention, others are not favoring. That is when we attempt doing a systematic review and finding a conclusive answer by doing a meta-analysis. But we cannot, when can people ask, when can we do a meta-analysis? So you need at least 2 studies, more than 1 report to summarize the results. And when the characteristics of the studies are sufficiently similar so that it makes sense to combine them. As ma'am said, apples and oranges shouldn't be combined. When the data are available in the form, we need to combine them, and outcomes are measured in a similar way. Do not perform a meta-analysis when the studies are too much different from each other, and studies must address same question, and meta-analysis will be meaningless and genuine effects may be obscured. So as ma'am said, meta-analysis can be misleading if we combine heterogeneous studies together. Steps in doing meta-analysis is first is to we have to define the comparisons. What are we going to compare with what? Then decide the outcomes for each of the comparisons. What will be the outcome that we are looking at? And then we retrieve data from the collated studies that we have included in the characteristic of included studies. We take out the quantitative data and fill in for intervention studies in the Revman or any other software that you are using, entering and pulling the data, and also explore heterogeneity. This was also very well covered in the earlier talk, and we are supposed to not do a meta-analysis when the studies are too heterogeneous. So sometimes we get for review, sometimes systematic reviews are sent to us to review, and where the heterogeneity is like 90%. So what will you make out? You cannot believe the results that the meta-analysis is showing. They have just published is for the sake of publication, but it doesn't make any sense. So therefore we should not combine studies when the heterogeneity is too high. So this is a template that shows the option of analysis under Revman software, and there are some methods are given under default. However, there is a chance to change it based on your protocol and based on your use. So this is a forest of lines. So we have all heard and we know about forest plots, but why are they called as forest plots? It's because they resemble a forest of lines, although horizontally. And just to people who are unfamiliar, although I know in this August gathering everybody is a learned scholar and they have all come across forest plots. So the headings explain the comparisons. This is the headings explain the comparison again. Yeah. Raw data for each study is shown. Like there are 7 studies included here, and for each study the intervention and comparator arm data is shown, and down below is the total the sum of the individual study sample size and the total number of events. So this is the total data for all studies, 277 to 90, and total events 58 versus 46. So this is the weight given to each study. So how the weight is also given by the software only. We don't have to calculate, but there is a calculation, and it is on an inverse of variance is taken into consideration. So the sample size and the event rate both play a role in how a study will be given. A sub-study with more sample size and which contributes more events will be weighed higher than other studies in the meta-analysis. Then this is the effect estimate for each study with their confidence intervals, and this is the graphical representation. And this is also again the diamond below there, which is the pooled estimate of effect size with its confidence interval. This is the template for where we write the systematic review in Cochrane. So this is the RevMan. This is now open for the review because we are doing data collection and all these things open. When you are at the protocol stage, not all these headings are highlighted. So this is one of the ways of conducting systematic review in the Cochrane. Having done all of that, then you have to the result. What all will you include in your results? The characteristic of included studies, the data analysis, the figures. So you have now forest plots, funnel plots, risk of bias, and however, coming to funnel plot, which is for publication bias, we cannot conduct a funnel plot for less than 10 studies. So at least 10 studies should be there in our meta-analysis to be able to do a funnel plot. So all these figures are there in RevMan. Then you interpret your result, write, consider the strength of evidence, consider their applicability, and then write up and publish. So this is again showing the funnel plot, and it plots the effect size against the sample size of the study. And to study the funnel plot, look at the lower left corner. That is where the negative null studies, as you mentioned, negative trials that are not published, so that become part of a grey literature. And our review will not be comprehensive unless we also look for the grey literature and find out about the negative studies. So this is what is meant by a funnel plot, inverted funnel plot. This is the next step which will be taken up in the afternoon, so I will not go into the details of this, grading of recommendations. So thank you for your attention. And this is a list of different softwares which are available for conducting a systematic review. Thank you very much. Thank you.